welcome everybody to this ACNS functional neurosurgery webinar. We'll have the first talk by Professor Masahiro Sawada, and we can start with the comments, opening remarks from Prof. Kato.
Much. So it's a great pleasure to have such a wonderful functional webinar. I think functional neurosurgery is it's very recently so many attractive and so many population who want to have interest. I think Sawada Sensei and Dr. Nicolai is one of the top leading professor of this area. So I think very much looking forward to big lectures. Thank you very much.
Thank you very much. So I'll hand this podium over to our chairman, Professor Hiroki Toda.
Yes, thank you very much.
Please.
Yeah, so okay, so should we start?
Yes.
The series? Okay. So our first speaker is Professor Masahiro Sawada. So he's going to talk about his clinical and also basic research topic on the spinal cord and it's the control connected with the basal ganglia. Okay, so Professor Sawada, could you start your lecture, please?
Thank you, Professor Toda. I'll share my slide.
Yes.
Slide. Thank you, Professor Toda, and thank you, Professor Kato, for giving me a chance to talk my latest research topic. The content of the speech is relatively related to the basic research, but I hope you will enjoy the result of my research. The title of my presentation for today is Orbitofrontal Cortex Gates the Voluntary Movement Execution in Humans. Now, this one. So, now I drank the water in my brain. Now my reward system calculates my internal state. So which is, am I thirsty or not? And then the reward system also calculates the external condition, which is the distance between me and the water bottle. And then my reward system decides to drink the water. And then I reach my hand to the water bottle, and then I drank the water. The fundamental question of my research is what is happening in our brain between the decision making and motor execution. So, sorry. The sensor motor cortex is the source of motor execution. This is fact. I think there's no doubt about this. But little is known about the upstream of the sensor motor cortex. The question is, what drives sensor motor cortex? So, recently, the idea suggested that orbitofrontal cortex plays an important role for the motor execution. So far, the orbitofrontal cortex is thought to be the center of the reward system, and there's no direct connection to the sensor motor cortex. So it is still unclear the connectivity between the sensor motor cortex and the orbitofrontal cortex. The aim of this study is to clarify the connectivity between OFC and the SMC for the motor execution in high time resolution by using electrophysiological way. So in this study, we recruited 22 awake surgery patient and 1 SEEG implant patient. Among these 23 patients, we were able to conduct electrophysiological study in 7 patients. Maybe we're a neurosurgeon. Maybe this scene is familiar with us. This is all our settings. There is a researcher here, and the operator is doing a surgery, and there's a monitor in front of the patient's face. I'll show you the layout of the electrodes. So we basically use a 16 contact electrode for the sensory motor cortical recording. And this electrode are also used for the SAP and the MEP monitoring. And this is for SMC recording. Before the opening of the Sylvian fissure, it is difficult to put the electrode to the orbitofrontal cortex. However, once the Sylvian fissure is opened and the CSF is drained, as you know, the brain gets slack. And after that, it's easy to put the electrode to the orbitofrontal cortex, like that. And basically, we use a 1x4 contact electrode for the recording and the stimulation for the orbitofrontal cortex. And this slide is showing the task setting for the study. The patients are requested to squeeze the egg-shaped dynamometer of the hand grip force. And then this grip force is sent to the intraoperative recording system, the recorded. And as I said before, there is a monitor for the task just in front of the patient face. The Q, which is the circle, colored circle, is presented for 4 seconds. And then, as soon as the Q disappears, the horizontal bar appears in the monitor. The horizontal bar means the goal of the grip task, grip force. The grip force is visually feedback to the patient with this thick vertical bar. And if the vertical bar hits the horizontal bar, the trial is counted as a success, and the patient gets the imaginary money. And there's a 3 type of Q, which indicates each condition. If red Q is indicated to the patient needs 60% of grip force out of his maximum grip force, and he gets highest reward, which is 10,000 yen. And the green Q indicate the lowest cost and the lowest reward. And the purple indicates intermediate. And so the one session is consists of the 30 trials, and each Q were randomly immersed. And we simultaneously recorded ECOG signals from OFC and FMC. And furthermore, we also simultaneously recorded the grip force and the time course of the Q presentation. So as shown here, the Q offset, which is the disappearance of the circle, indicates the go signal. And then we also use the mechanical force onset as a trigger of the averaging of the EEG. Here's a coverage of the electrodes on the SMC in left panel and of OFC in right panel. Each black dot indicates each contact, and the colored circle indicates contact for the recording. And also here you can see the colored circle. This is contact for the recording in OFC. We included one patient of the SEEG implantation patient. So here you can see the blue circle. It's a contact for the recording in SMC and OFC here. So in this patient, we use the bipolar recording method. This is the result section. And this time frequency gram is the total average of the echo signals from all trials, from all conditions, from all patients. The upper panel indicates the results from the primary motor cortex contact, and the lower panel is the result from the OFC contact. And x-axis indicates the time in milliseconds, and 0 indicates the onset of the mechanical force. And the y-axis indicates the frequency of ECOG signals. And now here we can see that just almost 500 milliseconds before the start of the mechanical grip, which is a movement of the dynamometer of the grip task, the muscle contraction started. And almost 1 or 200 milliseconds before the muscle contraction, we can see the decrease of the beta band in primary motor cortex. And during the contraction of the muscle, we can see the activation of the high gamma band. I'm sorry, these lines indicates the rectified and Z-scored muscle EMG, which is muscle activity. This is like the start of the car, especially automatic car. So if you release the brake pedal, the car starts. And then you kick the acceleration pedal, the car gets faster. So the relationship is that. And that's just before the results of FC. Let me show you this the correlation panel. So this is the correlation between the high gamma bar, which is this red one, and the alpha beta bar, this blue one. The upper panel indicates the before the muscle contraction. And here, there's no correlation. The R is very low. The p-value is not significant. But during the after the force onset, we can see the clear negative correlation between high gamma power and the alpha beta power. So the increase of high gamma band and the decrease of beta band is really clear during the motor execution. On the other hand, we can see the OFC recordings. There might be alpha and beta activation at the beginning of the muscle contraction here. But it's not clear. So we change the alignment of the time. Now the 0 indicates the Q offset, which is the which means the decision making and the start of the grip. The relationship between the increase of the high gamma and the decrease of the beta band is the same. But now here, at the beginning of the muscle contraction, we can see the clear activation of the alpha band and the beta band. So this recording result suggests that alpha beta burst in OFC may be the signal for the start of the motor execution. But this is just the correlation. So far, the causal relationship is still unclear. So to clarify the causal relationship between the OFC and the primary motor cortex, we recruited the inactivation method by using the electrical stimulation with 50 Hz stimulation with a Q milliampere. And the stimulation was delivered at the end of the Q presentation, which corresponded to the go signal. And we observed what happened to the behavior and the ECOG signal on primary motor cortex. This is a result of the behavior. So X indicates the time, and the Y indicates the relative power for this black trace. The black trace indicates the grip power, so mechanical grip power. And the red bar indicates the Q's presentation. And the upper panel indicates the result before the stimulation. So this is a normal task. And the lower panel indicates the task with stimulation, which is the simulation task, the task with stimulation. So as you can see, during the stimulation task, we can see the very elongate the grip. So it takes time to complete the grip. Here is a sample case. In this trial, the patient cannot grip for almost 20 seconds. And we ask the patient, what is happening to you? And the patient's answer is that, really, I think I'm squeezing. So there is a dissociation between the patient's will and the reality. So patients are trying to grip the hands, and the reality, but the patient cannot grip cannot grip. This is the result for the behavior, and this is the result of the ECOG signals. So this time frequency diagram is aligned to the onset of the mechanical force. So the time course is the same as the first time frequency graph. The upper panels indicates the task before the stimulation, and the lower panels indicates the task ECOG signal with the stimulation. So we can see the decrease of the high gamma band here. And also in every trials, we can see the decrease of a high gamma band. Now, there's no clear difference between the decrease of the beta band. And this correlation is a relationship between the beta power and the high gamma power. Left one is the result of the correlation before the stimulation. And now we can see the clear negative correlation between the beta band and the high gamma band. So this is a normal trial. And during the stimulation, so this negative correlation is completely destroyed. So now we can see that the inactivation of OFC just before the start of the grip, the patient cannot grip in spite of his will. And the ECOG signal was disturbed by the OFC stimulation. So without the stimulation to the primary motor cortex, we can disturb the ECOG signal of primary motor cortex. So now the conclusion, the OFC inactivation induced the stoppage of the motor execution, but patient's will and the consciousness was not disturbed. The OFC gets the will of motor execution to the MR. Maybe when we deal with the patient with tuberculosis meningioma or olfactory groove meningioma, the patient looks apathic. So this might be the damage to the bilateral orbitofrontal cortex. So this apathy might be led to this connectivity between the OFC and the primary motor cortex. Thank you for your attention.
Thank you, Professor Sawada. Great presentation and a great scientific result. So we've asked the two discussants for this presentation, and probably Professor Sugita, any question or comment for this presentation first?
Thank you for the very interesting lecture. My question is, may I ask why you choose to measure grip strength rather than using tasks such as tapping or finger movement? So why do you choose a task?
Thank you, Dr. Sugita.
Yeah.
Thank you, Dr. Sugita, for the nice question. I would like to dissociate the strength of the power. So it's difficult to dissociate the power by using a finger tapping task. in this presentation, I can't see the result between the difference of the power, but actually, I'd like to see the difference of the power and the ECOG signals according to the power.
Is there any association with beta power or oscillation?
Mhm.
Which is a more efficient to the movement?
Thank you. There's no difference between there's no difference in the decrease of beta power among the difference of the power, but
Yeah.
high gamma activity is correlated to the intensity of the power.
Thank you very much.
So based on the reply to the speaker's question, so you are now investigating the significance of the reward activity, reward response in your scheme. Is that I'm not sure what I understand correctly.
At the beginning of the study,
Yeah.
I'd like to see the difference of the orbitofrontal cortex activity according to the reward. But actually, there was no difference between the reward amount.
Okay. Maybe
Now,
Hmm.
the meaning of the condition is just our intensity of power.
Okay.
Sawada sensei, one question from for Nepal. So when you put the SCEG lead in this case,
Yes.
did you put the SCEG lead bilaterally in the OFC for the 50 Hz stimulation? How was the practical approach? Could you explain a little bit more?
I'm sorry, could you say it again? In this patient, I inserted the electrode in one side.
Only one side, I see. So intraoperatively, when the patient is awake, did you put the SCEG at that time or you plan beforehand? How do you do that?
Intraoperative ECOG recording.
Yes. SCEG, you said you gave stimulation from stereotactic EEG, no? That is it different or is from the same ECOG lead that you stimulated?
So preoperative, the trajectory.
Yes.
Yes. In this patient is a epilepsy patient, and
Yes.
the OFC trajectory is a clinical reason.
Okay.
This OFC might be related to the propagation of epileptic activity. So we inserted the electrode to the OFC in this patient.
So one more question for you. So we have also done some cases of psychosurgery where we did the capsulotomy to going to nuclear accumbens, and we know that there are some connection of nuclear accumbens to the OFC. So is there any research that can be done to see those responses? Do you have any ideas about that?
Thank you for the next question. Actually, my previous work is related to nucleus accumbens, but that were monkey experiment. So during the recovery from the spinal cord injury, the nucleus accumbens plays an important role, like OFC. So the nucleus accumbens is the source of the recovery from the spinal cord injury. So the nucleus accumbens upregulates the primary motor cortex neurological recovery. But in human patient, we haven't done the study because the DBS to the nucleus accumbens is not covered by the insurance of Japan.
Thank you. Okay, thank you.
Yeah, thank you very much, the Professor Shrestha. A very nice question. Actually, that question crossed my in grade 2. So, the Professor Sawada, so you do the only left-sided the examination this time, this series, or you examine both sides? I mean, one. So some patient got the left side stimulation, and the other patient got the right side stimulation.
Thank
How
you.
was you? Yeah,
Thank you, Professor Toda. The side is not fixed.
no fix.
In the illustration, we illustrated to all electrodes to the right side, but in some patients there is a electrode on left side.
How do you estimate any other dominancy, side dominancy? So like, well, the right side of the patient had a left side dominant, or do you have any impression from your result?
I haven't analyzed the difference of the left and the right side. Yes, maybe we should analyze in the future.
Okay, all right, thank you very much. It's really a wonderful study, and actually, it's going to the field of psychiatric surgery. I'm sure you're going to examine those patients too. Okay, once again, thank you very much, Professor Sawada, your wonderful presentation.
Thank you. Thank you so much.
Thank you. Okay, so unfortunately, Professor Nikolai P. Cannot join this meeting, so well, kind of pinch hitter. Should I do my short presentation? Okay. I'm going to talk about the deep brain stimulation. So Professor Sawada just showed his EEG patient as well, but just talking about deep brain stimulation for movement disorders. So let me share my slide. Um, 1 second. Okay. So let me share this slide. So I'm not going to speak about the imaging for the deep brain stimulation of movement disorders. I'm Hiroki Toda from Osaka, Japan. So well, the important thing is that in the field of functional neurosurgery, always location. So the location is quite important for targeting and also implantation, and also in programming, the location, the information of location is quite valuable. So the objective of this presentation is the accuracy in targeted imagings. So we use the quantitative susceptibility mapping primarily to target the deep nuclei, and also we use the location information for the lead implantation, and also we refer the location and the DBS programming. So we called it the last part as the image guided programming. So once there's the kind of histological characteristics in the subthalamic nucleus, which is the most used nuclei for deep brain stimulation in a patient with advanced Parkinson disease, and also some tremor patients. So iron deposit in the subthalamic nucleus is quite heavy, especially in the Parkinson's disease, and we can see the here. Well, this image is not so great, but here the kind of dark spot representing the subthalamic nucleus in this picture. And there are various MR imaging protocols to visualize this subthalamic nucleus. And in this group, actually, they show the T2 star flash 2D is accurate. But now we relying on the quantitative susceptibility mapping to check the subthalamic nucleus. So the weakness of the susceptibility with the imaging is the kind of ballooning effect of the images, so which may disturb the accuracy of targeting. But using the quantitative susceptibility mapping, actually, this part of the study is done by Professor Sawada, who presented the last presentation, and we can see the better imaging of the basal nuclei, including the subthalamic nucleus. These images shows. Okay, so the benefit of this QSM imaging is that they can kind of very sharp border and a quite accurate location to localize the subthalamic nucleus and also red nucleus, and this right panel shows. And actually, this is very good for anybody who check the target. So we like kind of the survey using multiple examiners, and we check the accordance, how they locate the accuracy, the location of the subthalamic nucleus and also a red nucleus. So when they use the T2 weighted images, or when they use the SWI, the accordance is relatively increasing, but QSM is accordance is better than T2 weighted images. Okay. And this is also good for subthalamic nucleus, and also the border between subthalamic nucleus and the substantia nigra. Okay. And actually, this is quite go well with the our microwave recording during the operation, and actually the QSM estimated the distance of the subthalamic nucleus when we do microelectro recording, and it's quite accordant with the recording and the size of the SDN on the QSM images. And so we utilize this QSM for the DBS implantation. And our usual target is in the frontal border of the red nucleus, and anterior border, I mean, of the red nucleus, and also 3 millimeter lateral to the red nucleus to target the subthalamic nucleus. And this is images converted onto the standard MRI space, and this is actually the suggested STN target, so which is quite go well with our classic targeting based on the anterior commissure and posterior commissure and localization. So STN usually within the 11.5 to 12 millimeter from the midline, and 3 to 4 millimeter posterior to the metacommissure point, and 4.5 millimeter below the ACPC plane. And actually, this is also well for another the major target, glottis palpetus interna, which is usually localized within the 19.5 to 20.5 millimeter from the midline, and 2 to 3 millimeter anterior to the metacommissure point, and 2 to 4 millimeter below the ACPC plane. So QSM imaging for subthalamic nucleus and GPI is a better identification and a sharp images, and quite accurate and quite consistent the targeting, and they also provide the more precise targeting, but it takes time to calculate these images, and this is actually need to be done by brain extract imaging. That means the the scalp needs to be removed to calculate. So it may cause some discordance to do co-registration with other MRI targeting. So those disadvantages need to be resolved to do a further examination. And let me go to the implantation part. So if we lose the significant cerebrospinal fluid, if the patient has a very atrophic brain, the air comes in and the target moves in an unexpected direction. So that will destroy the accuracy of the deep brain stimulation. So to avoid these clinical settings, interpretive settings, we prefer to place the patient in just a simple flat position, complete flat position, and also slightly next extended. This scheme just shows how we can avoid CSF leak and pneumocephalus by setting the patient in the very flat position. So brain just slightly going to the gravity effect, and it will seal the trifine even after we open the dura. So actually, this is the interpretive pictures showing so you can see this brain is just underneath the dura without space. And actually, this is the just after the operation. So soon after the operation, we did a CT scan, but just only minimum errors recognized in this CT scan. So flatbed positioning is provide more accurate the trajectory settings in these DBS patients. And finally, let me briefly describe our image-guided programming. So this is actually done for the Parkinson's disease patient who had a unilateral STN DBS lead, and actually this image shows the 0.5 milliampere stimulation causing what kind of the target they stimulate. So actually this is the motor cortical input for the subthalamic nucleus. And this is okay. So this is the partially levodopa responsive limb patient, and she has a very difficult. It's very difficult to walk, and very unstable. So she had this STN stimulation and within the motor. And actually, we used the directional lead, and this is showing the how directional lead can stimulate the motor part within the STN. So the STN can have the associated part and the limbic part. So just only sensory motor part of the STN stimulated, we can avoid adverse effects using tiny STN. So actually, this is the post-operative stimulation. So no tremor. And actually, this image-guided programming is also useful for reprogramming. Reprogramming means the patient has a very long-term chronic clinical course, and we've done the repeated programming even after the 5 to 10 years after the DBS. And this graph shows the high scores means the clinically worse condition. So these patients had a very worse condition before the operation, and after the initial DBS, they got a good clinical conditions. But so like 5 to 10 years, the Parkinson's disease got progress, and patient got the worse the score. But we do the reprogramming, so the patient can gain the another clinical benefit from the reprogramming. And in such cases, we also refer the image guidance, so which can reduce the time for the programming, and also can benefit to avoid adverse effect from the too much stimulation in these conditions. So I think this is the last slide. So in targeting implantation programming, always we need a very precise location, and the combined with the preoperative and intraoperative and the postoperative imaging, we can provide a better the surgical outcome for the movement disorder patients. Okay, thank you very much for your attention. This actually, I'd like to acknowledge my colleagues for supporting this study. Okay.
So,
All right,
Sensei,
so
maybe you can ask the discussant, please.
yes. Okay. Well, we can
Thank you,
accept the.
Professor.
Yeah. Hi.
Thank you,
please.
Professor. Thank you
Yeah.
so much. So when we do STN DBS, we are trying to register the SWI image nowadays because we don't have QSF image. The accuracy is very good because we also do the pallidothalamic tract reasoning. So at that time also we try to figure the mammillothalamic tract and with reference to STN, and that we do with SWI image. So what do you say about it? Is it okay? SWI is very good for us.
Okay, thank you very much for your update. And actually, I really appreciate the importance and the valuable value of the SWI. And but in some cases, SWI imaging gives us the kind of a ballooned, like a larger the images, but maybe it due to the kind of local MRI protocol. So I'm sure you have a very good protocol for obtaining the very nice, very accurate SWI results. Okay, so thank you very much for your comment.
Sensei,
Hi.
any question or comment?
Okay. Yeah, actually, these works done with the Sugita, Professor Sugita and Professor Sawada. So
Usually, I use the QSM for planning the STN DBS. QSM images have the advantage of the being visually intuitive, even for physician, for not involved in functional neurosurgery. But I believe the main issue is accuracy of co-registration. If the challenge can be overcome, it would be extremely useful tool.
yeah, so actually that's the feeling on the QSM, because well, actually the Professor Sawada, when he was in our hospital, he made a very the precise co-registration program. So that's why we can work on with it. Professor Sawada, do you have any comments or any
Thank you.
sorry, yeah.
The QSM is consistent of the magnitude images and phase images. The magnitude image is like T1. So if you use the magnitude image, it's easy to co-register to T1 image. And the phase image also have the same coordinate. So you can apply all transform index.
Yes, yes.
Yeah.
Actually,
Yes.
those technical the issues you solve. So thank you so much again. Okay. So well, I think.
So, Sensei,
Hi.
so can I ask, because I'm not so familiar with your work, but for example, that Huria, so the movement disorder, the one of the movement disorder, sometimes we encounter the Huria patients. So at this time is can you treat for that case with your methodology?
Okay, so maybe we need to examine further examine what kind of urea he or she that has. So if it related to the so for example cerebellothalamic tract injury or some cerebellothalamic the dysfunction, we can apply the deep brain stimulation. But Huria is very complex disorders, so well, maybe just a close examination and also check the close MRI imaging, and if we find any cues for targeting, we can proceed the deep brain stimulation. So that's my feeling. New questions.
Dr. Raja, any question?
No questions from me. Thank you.
All right. So
what about Risha?
Yes.
Risha, can you present the short presentation from your side?
No laptop. I didn't bring the laptop, ma'am. I just.
Oh.
Next time. So sorry.
Okay, so next time. Okay.
Next time, ma'am. Yes.
Now I heard now you are boss.
No, in functional neurosurgery only, I am taking lead with Professor Pant and Dr. Preetham. Our team is here. Only in functional neurosurgery, not. Thank you. Yes.
Tola Sensei, do you know her?
well, I also, of course, I know, but well, kind of indirect.
Yes, we met in Osaka in AC.
Oh, I see.
ASSF last time. Yes. Yes.
Well, I think maybe the Russia, maybe you can invite Dr. Tola Sensei to your place.
Yes. Sure. Thank you.
I think
So is it time?
yeah.
Yes.
Nikolai, where is he now?
He's in Tashkent,
Tashkent.
Uzbekistan.
Thanks. So far.
Yes. So
I think
close, please.
Okay, so should I say thank you very much for Professor Sawada and also Professor Karo and Raja and everybody, also Professor Shirasa and Sugita for contributing this the very nice program. Could you add Raja?
okay, so we can
Thank you
but
so
this
much.
is a very important field, I think. So
Yes.
we are very promising future.
Yes.
So we look for the next time. Risha, maybe you want to say something?
Thank you, Sensei. We really enjoyed a lot. So we hope we will continue. We have a conference, Rizu. So Dr. Rizu has also come from Osaka. So she would like to tell something about the epilepsy conference. Just tell the date and invite.
So please say something.
Dr. Yokokato, I'm Rizu. I studied in Nara Medical University,
Ah.
and I'm the epilepsy surgeon here right now. And we have a Himalayan International Epilepsy Conference in September. So I can email the flyer over to you, and we would love to have you guys come here. Epilepsy, then on epilepsy, if you're interested.
You have a very good team, I think.
Yes, thank you, Sensei. Just epilepsy. Thank you.
Yes. Thank you very
Because
much.
of Professor Tyler, so we are always thankful to Professor Tyler. And we like to thank him a lot.
Thanks so much. Okay.
Okay, thank you very much. We'll